some basic assessment stuff, kind of operations, logistics, dealing with trauma scenes. Feel free to ask questions. I'll try to answer them to my best ability. A lot of you guys have been doing this way longer than I have and know a lot more than I do, so feel free to interject, correct me, give your experience, whatever you like. No, that was too far. No, it wasn't. So this is kind of the stuff we're going to cover. Just basic types of injuries that we can expect. A little bit on shock, what types of shock there are, the progression and stages of shock. We're going to go over trauma assessments and using the March algorithm, the trauma triad of death, which I think you guys are mostly all familiar with, triage, trauma centers, and then just a quick case study, pretty informally there. Just to start off with, I'm sure most of you guys are familiar with the fact that the stuff that we know about trauma largely comes from the military, right? So that's how we should be approaching a lot of the stuff we do treating trauma patients, because they're the best at it, they do it the most. That's where the March algorithm comes in. The triad of death was kind of developed or found through experience in the military. So just keep that in mind, using that mindset a little bit. So these are kind of the four main types of injuries, right? Penetrating injuries, blunt force injuries, blast injuries, burn injuries. Someone give me an example of each.
Gunshot wounds.
Gunshot wounds, great. Is that a high or low energy penetrating injury? High, right? What's an example of a low energy penetrating injury?
Stab.
Exactly. Stab wounds, right? How about blunt force? Just shout out examples. Right?
Falls.
Yeah, falls, autopeds, MBAs, right? Assault.
Baseball bat.
Yeah, perfect. Blast injuries. So there's kind of four categories of blast injuries. You guys know the four. You don't have to listen in order, but primary, secondary, tertiary, quaternary. Any ideas? So your primary blast injury is going to be the actual blast wave, or like the overpressure from the explosion, right? So that's going to mainly disrupt our hollow organs, right? So our GI tract, or eardrums. You can get like barodontalgia in your teeth, all sorts of that, like overpressure, that shock wave going through your body. The secondary injuries are going to be from flying debris, right? So that's going to be, you have your explosion, there's going to be shrapnel, there's going to be rock, whatever it is, it's getting thrown through the air, impacting your patient, causing penetrating or blunt force injuries. Your tertiary is going to be the actual human being moving with the overpressure and impacting another surface, right? So bomb goes off or explosion happens, you get thrown across the room into the wall, that's your tertiary injury, is where you impact the wall, right? And then your quaternary blast injury is going to be any residual injuries from other types of trauma. So your burns, chemical injuries, dust inhalation, any of that sort of stuff. Make sense? Questions? Burn injuries.
Vince.
Yeah, Vince, go ahead and talk a little bit about that.
Wear your SPF 100 when you're in the
So what classifications do we have for burn injuries? Like what stages are there? Vince is obviously full thickness burns. So superficial, right? That's your top layer of your epidermis, right? Just kind of your sunburn or your light thermal burns. Partial thickness is the next, right? So that's going to be partway through your epidermis, not impacting the subcutaneous fat or the muscle, right? And full thickness is going to be all the way through that dermal tissue and your subcutaneous fat and potentially in your muscle tissue, right? Are your full thickness burns going to hurt generally? No. Why is that? Right, you fried your nerve endings, right? So there's no longer any stimulus indicating that you've been burned. Hopefully your patient is aware, but they shouldn't be hurting like a superficial or a partial thickness burn.
Can I comment to that slightly?
Sure.
There's also called Jackson zones of burn injury, and around a third degree burn, what you also have second degree burn.
Right.
So the notion that you're not going to have pain associated with third degree burn is not entirely true.
Sure.
So just careful with that, because you will have associated burn, pain, trauma, especially with somebody that's conscious, even if they have a third degree burn.
Perfect.
Or a full thickness burn.
Thank you. That's a good point. Bring it up. We talk about this all the time, right? Doing a good size up, especially on trauma scenes, kind of viewing the scene and deciding what injury patterns you're expecting to see, right? We call it the index of suspicion. So if you have a motor vehicle accident, where are we going to see indications of certain types of trauma? Well, we might see spidering on the windshield if they're unrestrained, or we might see a deformed steering wheel. You might have seatbelt sign on your patient, right? Just keep in mind what you're seeing. Don't just look at your patient, also look at the whole scene and decide what you're expecting to see, because otherwise it's easy to miss stuff, right? I'm guilty of missing stuff on traumas. I think we've probably all missed something due to a distracting injury on a multi-system trauma patient before, right? So just keep that in mind.
Can I tell you another one to look for that I often find, especially when I was flying a lot? Center consoles. Look at center consoles in car on broadside type injuries, because we oftentimes think like, oh, the person got hit on this side, this is where their trauma is. But if they get squished and get a pelvic injury because of, and you can see it with damage to the center console, don't be afraid to look in the vehicle for stuff that you might not have picked up on outside the vehicle too.
Perfect. Yeah, like I mentioned before, right, there's a lot of experience in here. I've been doing this for like 2 years, so I certainly don't know everything to look for, so feel free to speak up, interject. Hopefully we'll all get the most out of that with some of those interjections. So these are just, right, some basic injury patterns we might see, right? You got your your motorcycle accident. We're expecting, head injury, thoracic injury, abdominal injury, right? Extremity injury. You can see everything with that, right? Obviously that head on up in the top right, kind of same deal. We're looking at crush injuries, all sorts of patterns of trauma there. Here we have more of an isolated penetrating injury, right? We're seeing the musculoskeletal damage, and then the underlying structure would be the lung there, right? So that's what we're primarily concerned about. Not necessarily, obviously given the context of the situation, not necessarily looking at other systems of trauma. And then that's looks like a pretty significant burn patient, right? With partial thickness burns kind of throughout his upper extremities and chest, as well as superficial burns. So just, some examples. So let's talk about shock for a little bit. 4 types of shock: cardiogenic, obstructive, distributive, hypovolemic. What are the 2 types that we're going to primarily see with trauma patients? Obstructive and hypovolemic, right? Give me an example of obstructive shock. Anybody?
Tension pneumothorax.
Tension pneumothorax, perfect. How about another one?
Tamponade.
Yep, pericardial tamponade. So those are kind of the 2 primary ones that we're going to see with a trauma patient. Other types of obstructive shock would be like a pulmonary embolism, right? We're not necessarily expecting to see that in a trauma patient. Kind of the 2 that come to mind, I think for a lot of us, are the tamponade and tension pneumo, right? That's our part of our H's and T's, reversible causes. So examples of hypovolemic shock. There's kind of obviously one primary one in trauma, which is? Great, exsanguination. Yep, we're bleeding out. We're not enough fluid to pump around. One that kind of defies the laws a little bit would be burn shock, right? You get aspects of distributive shock and hypovolemic shock in there, right? Because we're third spacing, we're leaking fluid out of our capillary beds, but we're hypovolemic also. So we don't have enough blood pressure, systemic vascular resistance to blood pressure, but we're also losing fluid, right? So just keep in mind there's a couple impacts of that. As far as cardiogenic shock, there's kind of 2 possible indications in trauma that we could see. Anybody think of those? They're pretty rare, not expecting to see them necessarily, but something to keep in the back of your mind.
Myocardial contusion.
Right, myocardial contusion and myocardial rupture, right, would be the other one. So in cardiogenic shock, obviously that's cardio, heart-genic, stemming from the heart, so the heart's not able to pump effectively. So again, kind of the distributive and the cardiogenic shock are less frequent in trauma, but if you're treating your patient one way, you're not seeing an improvement, or you're not seeing the change you're expecting to, just keep that stuff in the back of your head, right?
I guess you'd say the cardiac, the MI before you ran into the tree.
Yeah, perfect. That's another one, right?
I think one thing too, when we talk about trauma, summertime stuff, we have a lot of old people, like a very aging population. So you also gotta keep in mind where they're gonna present differently when given the situation. They're on grills,
Right.
lulls, all of the beta blocker kind of stuff. So like, homie might have his legs smoked, but his heart rate's 50. And you're like, well, what's that all about? just
Yeah.
keep in mind that they're medicated to keep their heart down because they have heart failure. So just remember on our feeble populations that they're gonna present differently than a healthy.
That's an awesome point. Yeah, what's another population that might present differently in shock? Pediatrics, right? They're gonna compensate better for longer, and then it's gonna be a steeper curve once they start decompensating, right? If we see a kid with a shit blood pressure, we're really behind the 8 ball on that one, right? So just keeping that in mind, thinking about
Pregnancy also.
pregnancy, yep. Thinking about all the different possible types of shock, how they might be affecting the patient, why the patient's presenting one way or another, right? I'm not going to get into the diagram there, that's just hopefully helps you visualize it a little bit.
One more thing with pregnancy and traumas. Like
Sure.
Car accidents is a big one. Anytime that we have any gestation of any 8 to 12 weeks and on, our recommendation will be always to take them to the hospital. Like I've had a pretty benign car accident, but what you forget is that the mom gets so stressed that they can actually end up miscarrying based off of what they experienced trying to save themselves, right?
Absolutely.
Any pregnant patient that's involved in any trauma, we are going to advocate for them to go to the hospital. Now, whether they want to or not, that's up to them, but we will always push for them to go to the hospital.
Perfect. Great point. Any questions on the classifications of shock, types of shock? Okay. Moving on. So after the initial phase, right, the initial insult of an injury, then we kind of get into the 3 stages of shock. So we have compensated, decompensated, and irreversible. You can see it all up there, right? And I think we're all fairly familiar with this. Like I said, just kind of an overview, right? But compensated means that we're still perfusing the vital organs, right? We have an appropriate level of consciousness. Our vital signs are relatively acceptable, right? So normal blood pressure is key there, right? Tachycardia, the patient's compensating with that heart rate to account for an active loss in blood pressure, right? We're shunting blood from our extremities into our organs, right? Our extremities can tolerate ischemia for a lot longer than our vital organs, specifically our heart, brain, kidneys, liver, right? Our GI tract can take ischemia for a while comparatively, but we're going to try and squeeze down that peripheral vasculature and redistribute that blood into what really matters. So as a consequence of that, right, we're going to see that peripheral perfusion is going to decrease, right? They're going to potentially have, pale or cyanotic extremities, delayed cap refill, right? Soft or non-palpable pulses in their extremities. We're not really going to see the decreased urine output in our setting, generally speaking, right? Because we're trying to get them to the hospital or from one hospital to another. But that's just an indication that the kidneys are being not perfused as well, right? Which down the road can lead to bigger problems, but that's a compensatory mechanism. Once those mechanisms start to fail, right, as that shock progresses, we're going to get into decompensated shock, and that's where we're going to start to lose that blood pressure, right? We're no longer perfusing the vital organs appropriately. So what that leads to is anaerobic metabolism, right? So we get elevated end tidal, we get lactic acid, potentially get myoglobin from our musculature, right, releasing that into the bloodstream. And all that's going to lead to acidosis, which is going to worsen that process, right? It's just a vicious cycle until we interrupt it. Renal failure is going to contribute to that acidosis as well once we stop perfusing the kidneys. Hypotension, rapidly deteriorating and irreversible shock. Like I mentioned, right, specifically in pediatrics, once we start to see that decompensation happen, we're behind the 8 ball. It's going to progress really quickly into irreversible shock. Then once we get to that point, we get to multi-organ dysfunction, or MODS, right? Multiple organ dysfunction syndrome. That's a really, really high mortality rate, pretty poor prognosis. We're not able to treat it very effectively. Patients are super acidotic, their mental status is decreased, right? Their urine output is next to nothing, and eventually that's going to lead to death, right? Any questions on that before I move on? No? Sweet. So, like I mentioned, right, we're trying to take a little bit of the military mindset in terms of how we approach our trauma patients. So this is what I found is the best algorithm to approach a multi-system or a massive trauma patient, right? Is going to be MARCH. Anybody know what that stands for off the top of their head?
Massive hemorrhage.
Massive hemorrhage? airway. Next. Respirations,
Circulation.
circulation,
Hypothermia.
hypothermia. Perfect. Yep. So, with our massive hemorrhage, I know you guys, I was actually gone for the RTF training, but I know that in the EMS skills lab last month and the RTF training, there's some heavy emphasis on tourniquets, wound packing, stuff like that. And we've had speakers come in before and talk about that. So I'm hoping that you guys are all confident, capable of putting on tourniquets, packing wounds, right, putting on chest seals, kind of all the basic trauma treatments, right, for hemorrhage. But first things first, when we get to a patient, we're gonna do a blood sweep, right? We're gonna expose, right, get them trauma naked within the extent possible, you know, on scene or in the ambulance. Do a good blood sweep, treat any major bleeding. So that's arterial bleeding or steady venous bleeding that can't be controlled with direct pressure and bandages, right? So whether that's through a tourniquet, if it's a junctional wound, we're gonna pack that wound, right? Use quick clot, right? That's a pretty important advancement that we have in our toolbox now. So make sure we're utilizing that. And then pelvic binders as well, right? That's one thing we can do, because massive hemorrhage doesn't necessarily mean exsanguinating hemorrhage, right? Or I guess external hemorrhage. They could be exsanguinating into their pelvic cavity, right? Or potentially into their thorax. So just keep that in mind, right? Your patient could be bleeding even though there's no blood on the ground, right? So make sure we're having a high index of suspicion for that, depending on that pattern of trauma that we're seeing, right? Questions?
That pelvic binder is probably our number one most missed
Yep.
thing that we can do in traumas.
I wasn't gonna speak up at the sake of being the guy that's always speaking up, but we just, we're doing a sims with our group at AirMed right now to include, it's a trauma sim. And we put the sim in front of our docs, our trauma docs, and ask them like, what teaching points do you want taken home? And I'm not gonna spill it to you guys, cause we're gonna have them come do it with a few of you guys just for fun. But they told us the intervention that they serially see under-deployed, underutilized, and that's consequential is pelvic binders. And that all of EMS, to include AirMed, are failing to put pelvic binders on people that it's indicated to do so. So their admonition to us, and the teaching point we're driving home to our people at AirMed right now is, any high mechanism event that supports the potential of a pelvic injury, you're better to put it on and not have them get into a shocked state because they're bleeding into their pelvis. Then you're like, oh shit, I can't see any external bleeding. They must be bleeding internally. Let's put a pelvic binder on them. You're already behind the 8 ball like Minam talked about. And so we're far better off to prophylactically put pelvic binders onto people, because what's the harm in putting it on somebody that doesn't need it?
Hurts.
There is, actually it doesn't.
Oh, does it?
No. A tourniquet will, but a pelvic binder won't. Even a properly placed pelvic binder won't, unless you bust it off the top of your trochanter, which is very rare. So, as a general rule, high mechanism events, long falls, that somebody falls to their feet or to their ass, autopeds, high mechanism motor vehicle accidents, motorcycle accidents, toss and thrown, jettison type accidents, put pelvic binders on people. Put pelvic binders on.
So on that note, not to get too far into the weeds we all have war stories, right? But I know Mitch was there, Gavin was there, I'm not sure who else was on the call. This about a year ago now. We had a motorcycle accident on Main Street, where church comes into Main. I was the tech on the ambulance, and patient's conscious breathing alert. Somebody pulled out in front of her, she was going about 35, 40 I think, got thrown off into the back of the car. And she's screaming in pain for a wrist injury, right? She's got a dislocated wrist. And I felt like I did a pretty good, thorough assessment. Rocked her pelvis back and forth, totally stable. She didn't really speak about it too much. She just once in a while said, yeah, my groin's kind of sore, but really my biggest complaint is the wrist, right? And she had a great blood pressure. She wasn't overly tachycardic, in my perspective anyway. I got her in the ambulance, did a secondary assessment, rocked her pelvis again, totally stable. We took her to Davis, expecting that she got away pretty lucky, and she just dislocated the wrist, right? So we gave her 100 Fent, really no other treatments to speak of. They took her into CT, she had an open pelvic fracture. Kelsey's A-shift crew ended up taking her to Ogden Regional for emergency surgery to get that pelvis replaced, or fixed, and get that bleeding stopped. So I'm certainly guilty of missing pelvic binders. I think we
So
kind
on
of,
that call, she gave us a clue, if you look
Yeah.
back at it. Remember scooping her up, scoop this patient up, what'd she do? She went and protected herself and grabbed her groin. So that was like that
Almost
telltale-
subconsciously. If you have somebody that's reaching for their groin, right, so almost subconsciously, it is a tell. You're a shitty poker player. It is a tell. They have a pelvic fracture, I'm telling you. And that you said, I didn't fell a rock. And by the way, your pelvis isn't heavily innervated. It doesn't have a lot of nerve endings in it. So it doesn't carry pain like an angulated wrist or an arm fracture or rib fractures do, all right? It's not innervated like the rest of your body often is. So it's not inconceivable that they don't have a bunch of pain unless there's a nerve that's actually impinged, which is rare, all right? So that was a great learning opportunity for him, and it's a good one to learn from. Just put one on. You're better off to put one on, for sure.
and that goes for everybody on scene, right? If you see something, speak up. It doesn't have to be the patient guy. It doesn't have to be the second paramedic or whoever's involved. If you're saying, this patient probably has a pelvic injury or whatever it is, speak up, even if you're not involved in patient care, right? Worst thing you get told is, I think we're fine, right? But it's better to speak up. If somebody would have said, hey, I think we should put a binder on this gal, I probably would have thrown one on just empirically, right? Even though I thought she was fine. Ultimately, I think she ended up having a good outcome, but it could have ended up a lot worse. So speak up, right? Use your own brains. Don't just kind of write off the patient as, okay, there's 2-3 medics or 2 EMTs and a medic working on them. Like, speak up, right? Good if I move on? Okay. Airway. So talking about airway, right? This is all going to be based on our patient's level of consciousness and their ability to protect their own airway, right? So we have basic adjuncts like OPAs and MPAs. We have supraglottics and iGels. We have intubation, and we can facilitate that with RSI, right? And then we have cracks. Use your clues and your patient status to inform your decision about which airway to place, right? What are some? I think we all kind of know the indications for each one, right? As far as getting more and more advanced, what are some contraindications for each type of airway? So start with like OPAs. Gag reflex is a big one, right? How about NPAs?
Facial trauma.
Facial trauma, right? We don't want to increase that intracranial pressure, and we don't want to misplace that NPA. How about iGels? Is there any contraindications for those?
Gag reflex.
Gag reflex is another one, right? And then potentially the possibility for the patient to aspirate, right? They form a pretty good seal, but it's not a definitive airway in being an endotracheal tube, right? So if we think this patient, like a head injury patient, right, they have a pretty high likelihood of vomiting at some point, there's, some good indicators there to maybe pull the trigger early on RSI, right? I don't know about there's the old adage of GCS less than 8 means intubate, right? Sometimes patients with a GCS of 8 have a perfectly adequate gag reflex or protecting their own airway, right? But there's always the potential for compromise down the road. I think iGels are great. I think that we should use them frequently, but there are patients out there where it's not appropriate for, right? How about endotracheal tubes? Any contraindications? Or for RSI, any contraindications?
Hop killers.
Hop killers, right? You guys want to list those off for me?
Hypotension.
Hypotension, oxygenation,
Oxygenation problems.
Okay. pH, yep. Those are the big ones, right? Easy for us to use acronyms to kind of cognitively desaturate, right? So keep those in mind. And then any contraindications for a crank to speak of?
Identify your landmarks.
Right, well, that's a relative contraindication, right? Because maybe you can't identify your landmarks, but they don't have an airway. What's the more pressing problem, right? That's our rescue airway. That's our last ditch effort. So
I think really the only distinction is surgical versus needle.
Sure.
Like age differentiation would be the two.
Sure.
So.
who do we use needle cracks on? Hopefully nobody, but pediatrics, right? They're not very effective at all. We can give an inhalation breath fairly acceptably, but it's kind of like that obstructive pathology in your asthma, your COPD patient, right? They're not able to exhale through that needle or that catheter well at all, right? So we're risking a pneumo, we're risking barotrauma in the lungs, right? And we're not ventilating very well at all.
So complete sidebar, but in the very near future, we're switching to it at the other place. There is now a needle crank that's got a little larger diameter that you can actually get ventilation, not just oxygenation. So I think you might see us maybe add that to our repertoire here.
Perfect.
By the way, every time you see these listed, you all see that sequential, like OPAs, iGels, innovation, Crike. And we all kind of get this notion that Crike is what? Last. Is it entirely possible that Crike is your very first thing?
Yes.
Yes, absolutely. Don't hesitate. If you're at Crike, Crike compute.
Questions on airway? Okay, moving on. Respirations, right? So we're good at this, right? It's part of our standard assessment for all of our patients, right? We normally do our ABCs. This is just a little bit of a different algorithm. So breathing is B, respirations is R. Assess your patient's respirations and their own respiratory effort, right? Do they need assistance, right? Do we need to start bagging this patient right away? Are they ventilating appropriately, but they have the potential to decompensate or lose that respiratory effort? In trauma, we kind of talked about that obstructive shock, right? So how are we going to treat that obstructive shock? Being a tension pneumo, a cardiac tamponade, the two primary ones. How are we going to treat that? It's on the board. Okay, needle Ds, right? Hopefully we're going to get finger tours somewhat soon, given the last few months and the mistakes we've been making. I don't think Dr. O's super keen on giving us new exciting things to try out.
Actually, it's not Dr. O. Dr. O's 100% on board. It's the position of the state right
Okay.
now and where that fits in the skill set. So
Well, there you
as
go.
soon as there's a decision made, we will have it one way or the other.
Well, there you go.
Just so you all know, it is considered at the state level right now to be part of the critical care curriculum that they're developing to be a critical care skill. It's not considered even a paramedic level skill right now. So that's the distinction. So as soon as they get that settled, we'll get it dealt with.
Perfect. Let's say we have a penetrating injury, right? Gunshot wound. How are we going to treat that? Chest seal, right? Occlusive dressing. We're trying to prevent that pneumo from getting any worse that they inevitably have by penetrating that thoracic cavity, right? I just wanted to pose this question to you guys, right? We've all tried to listen to a patient's lungs with a stethoscope when it's too loud, there's too much road noise, whatever it is. What are some ways that we can assess respirations without using a stethoscope?
Put your hand on their chest.
Right, assess their chest rise, right? What's another one? Their work of breathing. Yep, absolutely. Their positioning, right? Obviously their SpO2, right? Are they oxygenating? It's not a perfect indicator of ventilating or ventilatory status, but it's ultimately going to reflect their ventilation at some point, right?
Accessory muscle use once their chest is open.
Absolutely.
And exposed. You can
So-
watch
Retractions.
And that's the key right there, the exposed. I've told this story before, I'm gonna make it quick. Years and years and years ago, I had a grandpa chasing around a little kid in a house. Slipped and fell on a vinyl linoleum floor, went into a cabinet. The crew there was like, hey, he's good, you guys can bail. And we're like, yeah, that's totally cool, but we were in this awkward spot, so we just stayed there. And you could kind of watch this old boy, and like, he did not want to breathe. And I'm like, is he all right? And they're like, no, he's totally okay. And I'm like, lift his shirt up for me for a minute. And they're like, he's okay. And I'm like, lift his shirt up for a minute. And as soon as you lifted his shirt up, you could see his ribs going like this, right? And so it's super important that we, like, I know that we do ish, counting breath sounds and everything else, but like, you gotta look at people's chests once in a while. And if they're hurt, you gotta expose their chest and watch them breathe. You gotta watch them breathe, so.
Perfect. Yeah, so with that, right, we have chest trauma, we have decreased ventilatory effort, but appropriate level of consciousness, right? We expose that chest, we see a flail segment, right? Paradoxical chest wall movement. How are we going to treat that?
RSI.
RSI, perfect. But ultimately, positive pressure ventilations, right? The problem with that flail chest is that we have a negative pressure ventilatory drive when we're spontaneously breathing. The way we treat that is by basically splinting that flail segment out against the chest wall, right? That's going to decrease that trauma, any laceration of the subcostal arteries, right? Any worsening of any sort of pneumo or hemo, right? So don't be afraid to assist your patient's ventilations with a bag. or RSI them. And then also treat them, treat their pain. I've never had it happen. I would imagine that having a flail segment or any sort of, displaced chest trauma is going to be fairly painful. So if their blood pressure will tolerate it, do your best to treat their pain, right?
What do you think, Corey? Eating some handlebars on a bike? Is that right?
That sounds about right. Catching a tree with your clavicle.
Bingo. Okay. Circulation. So we got a couple lists on the board. How are we going to appropriately assess circulation in our trauma patient?
Threshold assessment.
Right. So we got our mental status, right? Their color, their distal pulses. Anything else we can do to kind of assess how well they're perfusing? Cap refill's a great one, right? Blood pressure, right? So, those are the big ones. Anything I'm missing? No? Okay. This is something I don't think we talk about a lot. I don't know how many people are familiar with it, but the concept of shock index. I wasn't taught it in paramedic school. That was just something I learned kind of throughout the last couple of years. And I don't necessarily need you to remember that normal physiological shock index is 0.05 to 0.6 or 0.5 to 0.7, or the decompensation occurs at whatever decimal point. But the idea that heart rate divided by systolic blood pressure is your shock index. When we simplify that, basically if they are more tachycardic than their systolic blood pressure, that's a problem, right? Or is that heart rate closes in on their systolic blood pressure, right? As the heart rate climbs, blood pressure falls, and then eventually switches, that's an indicator that we're starting to go farther and farther down that shock pathway, right? So like I said, don't necessarily remember the formula, any of the values associated with it. Just remember that heart rate increasing, blood pressure decreasing, that's a problem, right? I think we're all fairly familiar with that, but just another way to look at it. Fluid resuscitation. This is something that's changing in the literature kind of right now and ongoing. But the military specifically has been putting out a lot of literature about this, that we're actually worsening a lot of our traumas by giving fluid boluses, right? At least for us, what kind of fluids can we give? There's crystalloids, right? With crystalloids, that causes a lot of problems. I'll get to the trauma lethal triad here in a moment, but it worsens acidosis. If it's not warmed, it worsens hypothermia, right? It washes out the clotting factors. So giving a crystalloid bolus kind of worsens every part of that trauma triad, right? So ultimately, if somebody doesn't have a blood pressure, they need a blood pressure. But we need to be judicious about who we're giving crystalloid boluses to, how much we're giving, right? Obviously following our protocols within that, but I would say try and change your mindset. If you're at the point right now where you're thinking about giving aggressive fluid boluses to your exsanguinating patient, change that mindset to how much can I get away with not giving them, right? Ultimately, what that patient needs is blood. They need blood products, whole blood, to give a complete fluid resuscitation, and we're kind of just kicking that can down the road by giving them a crystalloid, which is LR or NS, right? Can somebody tell me what permissive hypotension means?
You're gonna be okay with the lower blood pressure?
Right. So normally we say, right, our normal blood pressure is 120/80, right? Theoretically. So in our hemorrhaging trauma patient, we need to change our mindset so that we're accepting a systolic blood pressure of 90, right? Thereabouts. Kind of along the lines of that fluid bolus, that crystalloid, we don't want to be washing out that clotting factor, right? So we're not going to treat them, if their blood pressure is 80, we're not going to give them a 2-liter fluid bolus to get them back to 120, right? We need to be accepting the fact that 90, as long as their mean arterial pressure, right, their MAP is okay, we need to accept that the way it is, so that we don't worsen that hemorrhage. Okay?
What is an okay map?
Anybody knows? 65 is our general, right? There's kind of one caveat to that in our trauma patient, which is TBI, or increased intracranial pressure, right? What are we titrating our MAP to for that patient? Lower or higher? Higher, right? Why is that? Overcome the intracranial pressure, right? We need to have a higher blood pressure because we're expecting that their brain is swelling and leaking. So we have to perfuse that brain, right? If we don't perfuse the brain, what's the point? Right? So we're going to try and get that systolic blood pressure up. Instead of 90, to the 110, 120 range, so we keep perfusing that brain. Copy? TXA. We obviously have TXA we carry it in our ALS bags. This is a awesome new treatment that we have. Anybody know the dose off the top of their head? 1 gram, right? And what are the indications for TXA? Or kind of, I guess, the prerequisites. So we're suspecting hemorrhagic shock, has to be within how long of the onset of injury? 3 hours, right? Can we give it to pediatrics? No, right? So just hoping that you guys are aware of it, keeping it in mind. It's a great addition to our treatment, but we need to be focusing on that BLS treatment before we're starting to give TXA, right?
So interesting thing about TXA too, the studies have fleshed it out pretty well. The sooner you give it, the more efficacious it is. So if you think to yourself like, oh, I got a 3-hour window, that's actually, you do, that's true. But if you get it in within the first 30 minutes, the first hour, it's actually more efficacious than if you get it in between hour 1 and hour 2. So much like aspirin with somebody that's having an MI, you're like, hi, Brady, I understand you're having chest pain. Yes, do you have an allergy to medicine or to aspirin? No, great, chew these. Now tell me about your chest pain. TXA is a lot the same way. If you've got known or suspected bleeding, give it, all right? Give it, for sure.
Perfect.
So what's your thoughts on that too? Like say you got a head bonk and you're
Give
like,
it.
just give it to them?
Crash 3 trial actually was specific to stroke patients, you giving it in hemorrhagic stroke, and they actually had a benefit in patients that had hemorrhagic stroke. It is not prothrombotic, it does not cause clots, it keeps the fibrin mesh that your clots adhere to in place longer, it does not form clots. Next knucklehead doctor, paramedic, nurse, whoever tells you that it forms a clot, tell them they're dingling, all right, nicely, tell them they're dingling, and give it for sure. They give it, we give it any kind of bleeding you can think of. Postpartum hemorrhage, give them TXA.
Are you telling us to give them on head bleeds?
I'm telling you, not
Suspected.
Yeah, but how are you gonna know
in
if it's-
trauma. Okay, let me back up. Am I telling you to give it in a stroke that you suspect to be a hemorrhagic stroke? No. Could you? Yes. Am I telling you in somebody that's got a multi-system trauma that to include bleeding, known or suspected, that you also think that they have head trauma in, can you give it to that person? 100% you can. 100%. So.
Cool.
Thanks for that.
Yeah, any questions about all that? Okay.
Is every AirMed copter equipped with blood products now? Or is it
Yes,
still?
2 units of whole blood.
2 units?
2 units of whole blood.
Perfect. Okay, hypothermia.
Let
I
me
think
speak to that real quick. I would say that in the 18 years that I've been at AirMed, the thing that we've done that's most changed outcomes is adding whole blood. So that speaks to a couple things. A platoon now in general, if you're on a scene that you think you need a helicopter, I would just assume you brought the helicopter to the scene, not that you did a rendezvous. Opens a whole can of worms at the hospital that we don't need to deal with, that I'd rather not deal with. We'll talk about that at another time. But if you think you need a helicopter, bring them to the scene, unless you're literally a block away. If you can see the sign that says Davis Hospital, whatever version of ownership it currently is under at the moment, then go to the hospital. If you can't see the sign, bring the helicopter to you. Radio them in advance that you have a bleeding patient. They will have the bag spiked and in a warmer and ready to put on your IV the minute that they land. That's how much we emphasize that right now. It's our #1 intervention that we're advocating right now. So.
Okay, moving on. Hypothermia, I think this is probably what we're most guilty of neglecting with our trauma patients, right? Because patients can become hypothermic when it's 80 degrees outside, right? That's a real thing. So we need to be focusing on actively warming our trauma patients, right? Crank the heat in the ambulance, use hot packs, use blankets, warm our IV fluids if we can, right? It's part of the lethal triad, right? But it also worsens, right? It goes around in kind of a circle there, right? It worsens all the other aspects of trauma, right? So the blood doesn't close effectively. The patient becomes more acidotic because they're having to use anaerobic metabolism. right? Yeah, so on and so forth. So, let's
To
see.
the tune that they were putting people in sleeping bags in the middle of Afghanistan when it's 120 degrees outside. So when you think it's uncomfortable for us, it's still not warm enough for them.
Let's talk, I mean, why are our patients becoming hypothermic, right? Let's say you have your gunshot wound to the abdomen that's, you know, exsanguinating, right? Why is that patient becoming hypothermic?
Blood is shunting to where it needs to go.
Blood shunting, right? What else? We're losing blood, right? So we're losing a lot of body heat. Our metabolism is stressed, so we're not focusing on thermogenesis, right? We're not creating enough body heat. I mean, those are the big ones, right? Anything else you just think of? Okay. So, like I said, focus on, you know, passive and active rewarming, right? We're trying to bolster the patient's ability to warm themselves, and then we're also, depending on their severity, trying to actively rewarm them with the heater in the ambulance, warm fluids, hot packs, whatever it is, right? This is super important. Don't neglect it just because you think you have better stuff to work on, right? We need to keep our trauma patients warm. Burn patients especially as well. So, talked a little bit about it, but the trauma lethal triad, before I click over, somebody give me the 3 prongs of the lethal triad.
Acid, hypothermia,
Hypothermia,
acid,
acidosis, right?
clotting.
Yeah, coagulopathy. Perfect. So this is generally going to be associated with severe blood loss, right? So it's kind of hard to visualize where it starts because all this is happening throughout the shock process, right? But we're losing blood, so we're losing body temperature. That's worsening the clotting factors. Now we have coagulopathy, right? We're unable to compensate for that blood loss, right? As we start to lose more blood, we get increased lactic acid and other metabolites of ischemia in our blood, right? So now we get acidosis. That's going to worsen the clotting problem. It's going to worsen our metabolism, right? So we get more hypothermic. So it just goes around and around and around the circle. Total vicious cycle, right? We need to be able to interrupt, if we can, all 3 of those legs of that triad, right? Questions? Okay. Moving on a little bit to triage. Luckily, I think, knock on wood, we've been fortunate not to have a ton of MCIs lately. But I think that we could all probably use practice in triaging, right? On our basic Bravo 1050s, right? When we have 3 or 4 patients that are all alpha condition, we all know how that goes, right? I think I'm guilty of it, but one thing we do is you get on the ambulance, give your arrival report, say we're out triaging, and then you don't say anything else on the radio, right? So part of that in your triage is you need to give a triage report so the incoming units are aware of, you know, what level patients you have, right? There's only one real difference between adult and pediatric triage, right? Which is going to be the presence of assisted respirations. So in our adult triage, we're going to start, we call these the walking wounded, right? We're going to call out anybody that can walk to a secondary collection point. We're going to classify them as minor, barring any obvious, amputated arm or severe hemorrhage that's able to walk, but they're obviously a red patient, right? Then we're going to go around, we're going to triage, we're going to do airway maneuver, right? So the old school is to do the head tilt chin lift. I would recommend, and I think the literature recommends, doing a jaw thrust with that as well. Obviously in the presence of C-spine injury, but generally speaking, if you look at an x-ray under fluoroscopy, when you give that jaw thrust, the airway opens a lot more effectively than just doing the old school head tilt chin lift, right? So reposition the head, but also give them that jaw thrust. And if they don't spontaneously breathe as an adult after we appropriately position that airway, we're going to classify them as black, we're going to move on, right? If they have spontaneous respirations after we position their airway, we're going to tag them red, right? Then we're going to go to our next assessment, which is going to be RPM, right? Respirations greater than 30 per minute, it's going to be immediate. You can also say, I would say less than 10 per minute, right? If they're breathing agonally. They might be salvageable, but they're obviously not breathing effectively. They're going to get tagged red, right? And I apologize for the blurriness of this. Looked better on the screen, but
Let's chat about that for a minute, because in my mind, we should be placing people in recovery positions. If we're doing a jaw thrust, it almost screws us if they do start breathing. Because now if we let go and they go back to an obstructed airway, we're not gonna continue
We're
to
kinda
render
stuck.
care. So I'd almost say because that's kind of what we were doing with RTF is recovery position. If you start breathing, you're a red.
Sure.
If not, you're a deceased or expectant, right?
Sure.
I don't know if that's official or what your guys' mindsets are on that, but
I can tell you my position on it I think that's totally appropriate to put them in the recovery position, right? But I would say to assess their spontaneous respirations, we're gonna do that
I can see
maneuver,
us
right?
getting drawn into that, right?
Sure.
Like, oh shit, now they just stopped breathing. Well, now I'm stuck here holding the jaw thrust.
Sure.
Well, actually,
Right.
we need you to do other stuff,
So, yeah, so I think a combination, right? So
Right.
position that airway, and then when they start breathing, put them in the recovery position and proceed with your triage, right?
Nice.
Perfusion, right? So we're basically just doing a quick and dirty assessment of the blood pressure, which is assessing a distal pulse, right? We're gonna go to that radial pulse. If they have one, great. If they don't, they're gonna get tagged immediate because that's not a totally reliable indicator, but can be fairly reliable that, or indicate their condition, right? And it's not really in that chart, but obviously control any major hemorrhaging, right? If you can put on a tourniquet and stop an arterial bleed immediately, we're gonna do that, right? Try and preserve that patient. I think that kind of goes along with perfusion, and then to finish out RPM, mental status, if they're altered, then they're gonna be tagged red, right? Everybody else, barring provider judgment, is gonna get tagged yellow. So like I said, the only difference to speak of with the jump start or the pediatric triage is going to be assisting their respirations. Why would that be important in a pediatric patient to give them 5 rescue breaths?
They're respiratory driven in a lot of cases.
Right, so one of the key causes of cardiac arrest in pediatrics is going to be hypoxia, right? So if we can revive them with a short stint of rescue breaths, 5 rescue breaths, right? Then we're going to be slower to tag them black than tag them immediate, right? If we can get their respiratory drive back with a little buffer, just give them a quick 5 breaths, then that patient's more likely to be salvageable, right? Whereas adults, once their respiratory drive's out, probably in cardiac arrest, we're going to tag them black, right? Right, walking wounded, we got that. Apneic and no pulse after head tilt or airway positioning, right? Deceased. Apneic after 5 rescue breaths, deceased. So that was the key there, right? No pulse. Obviously they're tagged black. And then after we give those 5 rescue breaths, again, if they have spontaneous respirations, we're going to tag them red. Then we're going to go back to that RPM, I would say, right? The AVPU is really its mental status, right? It's just on this chart expressed differently. So respirations are going to be less than 15 or over 45 per minute, right? We know that pediatrics have an elevated respiratory rate intrinsically, so those parameters are just going to shift a little bit, right? So if they're outside of that 15 to 45, we're going to tag them red. Same assessment for perfusion, right? If they don't have a distal pulse, we're going to tag them red. And then mental status, if they're unresponsive to painful stimuli, then we're going to tag them red. And then moving on from that, tag them yellow. Questions? I know it's super exciting, Cannon, I'm sorry.
It's his face.
You can't help it.
Grace,
How does triage change with electrical injuries?
anybody?
I didn't hear, sorry.
How does triage change with electrical injuries? So electrical burns, right, electrocution.
I guess
What
scene
about
safe,
cardiac
right?
arrest? But what about cardiac arrest? If they already have an electric.
We're gonna be slower to tag them black, right? Because if we can defibrillate them on an
Can we at
electrical
least
injury.
establish that it's deceased or expectant?
What'd you say?
Deceased or expectant?
They've changed it, right?
Sure.
I know.
We love you long time. Just that when you walk into walk in and you're, because people hear us, and this is what you talk about, this is for everybody, not just, but like you go in and you do a triage, hey, I've got 3 yellows, 2 reds, and 3 blacks.
So we don't
Fair
want
enough.
They're gonna be like, what? What does that mean? So, expectant, deceased,
immediate.
it just helped,
Sure,
it's just one of those,
Oh.
base brain function,
absolutely.
you're gonna go back to what you thought about 3 years ago.
I have sounded and will continue to sound like an idiot on the radio, so.
Yeah. Don't we all?
Yeah.
Expectant.
All right, anything else on that? Okay, trauma center designations. what are our Layton hospitals rated at? 3? Okay, where are the nearest level 2s? Okay, Ogden Regional, right, and the level 1s?
We call them a soft 3 as far as the level 3s.
Yeah, is one of them really a 3?
Are we even gonna give them a trauma center designation? I mean,
Our ambulance is a trauma 3, we see.
yeah,
Yeah.
couldn't agree more.
Can they make it 15 minutes or not? If the answer is no, go for it. If the answer is yes,
Here's the only thing the only plug I would give, and it pertains to this. Both of them, these guys more so than these guys, are getting very good at getting blood on board quick. Their MTP protocol, and they're getting blood on board quick. They're doing a pretty good job of it. Are they the definitive long-term solution to anything? Are they a surgical solution? No, they're not going to be, they never are. But if you've got somebody that's trying their damnedest to die in front of you, especially from bleeding, get them inside, all right, and or land the helicopter and get, get blood on board. But if somebody's trying their damnedest to die in front of you, and they've been shot up by the cops or hit on a motorcycle or whatever, I know we give the hospitals, deservedly so, a bunch of shit. But if nothing else, they can get blood on board and then you can go to wherever you need to take them. So that's my only point.
Oh, I think that's a great point, right? I mean, we are gonna have to make a decision. Are we gonna bypass a facility to go to a higher level of care? Or are we gonna get to the closest facility and stabilize that patient with blood products, with pericardiocentesis, with a finger Thor, whatever it is, and then either transfer them out later or let that airmed team take him and go somewhere else, right? So be really cognizant and make a good judicious decision about, am I gonna drive past Davis Hospital to go to McKay, or am I gonna turn and go south on I-15 and go to the U when this patient has a blood pressure of 60 or whatever it is, right? So just keeping that in mind.
that's also gonna be the argument used against you if you make a poor choice.
Bingo.
So think about that when you're like him, Han.
Yeah.
Like, why would you? So do you have an airway problem? Is there a bleeding problem? Any of that? Because that's justifiably from the department's perspective, when we're using our brains to decide where, if you have any of those ABCs that you can't immediately manage, it sucks and everybody's gonna be a part of it, where we're gonna take somebody to Davis and then we're like, ah shit, we're gonna transfer them an hour later. And then it's a part of us being good team members, that when 52 takes one there, that when 53's on the transfer, that we don't say anything and we just go take them, because it's just one of those inevitable, ah shit, you're not gonna drive past Lake Niagara with a cardiac arrest, sorry. And if, heaven forbid they get ROSC, somebody's gonna transfer them out, and that's just the way it works.
We had a bad accident on I-15 years ago on the Layton Kaysville border northbound. And I'll never forget, Brian Cunningham was on it, and I'm like, we're gonna go to IHC Layton was just open. And I'm like, we're going to IHC Layton. He's like, Chief, and I'm like, we're going to IHC Layton. He gave me this look like, are you out of your fucking mind? I'm like, we cannot drive by a hospital that's a block and a half away. I can never make that argument with Dr. O, ever. We can't. All right, as good as EMTs and paramedics as you all are, we're not docs, right? Like a medic in the gutter is still not better than a medic in an ED, or a doc in an ED. Are they the end all be all? Nope, they're never going to be. But at the end of the day, they're gonna live because they got blood in an ER, not because you RSI'd them and gave them quick clot, all right? So.
Perfect. I don't think any of us need to memorize all this, nonsense, the laundry list of what classifies a certain facility as level 1, level 2, level 3. I just threw that up there. We can just talk about it briefly, but so level 1, right? 24-hour in-house coverage by general surgeons, prompt availability of care in specialties like orthopedic surgery, neurosurgery, anesthesiology, emergency medicine, radiology, internal medicine, plastic surgery, so on, so forth down the list, right? Obviously, that's going to be our tertiary care. That's where our sick patients are going to end up for their definitive care, right? Part of being a level 1 means that they have a little bit higher commitment to research, right? So, and just more resources, right? More ability, more specialties. So, in the trauma setting, one thing that the level 1s have that Davis doesn't have, that I'm not sure if McKay or Ogden Regional have, would be REBOA, right? Resuscitative endovascular balloon occlusion of the aorta, right? So we've got a significant hemorrhagic shock patient, right? They're bleeding out. We're trying to keep perfusing their vital organs. We're going to occlude that descending aorta and prioritize where we're sending that blood, right? That's one thing that comes to mind.
Interestingly, IMED is not doing rubella right now either.
There you go.
The U is the only one that is, so.
Um,
And the other two up north are not.
That's what I figured.
Yeah, they're not.
So,
Huh?
What did you say?
IMED is not doing rubella. The only place that is doing rubella right now is the U. So, and it's pretty rare, so.
Another one too with trauma, hands, eyes,
absolutely.
vascular, like regardless of extent or stability, if you have any, like somebody cuts their arm off, like that's the only chance they have of maybe it getting back on or off. So
Right.
the U is hands, eyes, to the point where late night or select health insurance, like they will pay for you to go to the U because they're not even, like Intermountain isn't even worth like going to try to get to where the U is on that. So hands, eyes,
Sure.
circumferential burns, all that stuff, we wanna get them to the U.
Another big part of it too is just staffing, right? I mean, I think most, if not all of us have taken a pretty significant trauma patient to Davis, and we've also taken a pretty significant trauma patient to the U, right? What's the difference? You take somebody to Davis, you get a doc, a couple nurses, an RT, and maybe a tech, right? You go to the U, you have anesthesia, trauma surgeon, attending ER physician, resident, like 3 or 4 nurses, a couple
What
clerks.
gets told when you get to speak.
Yeah, it's really exciting.
You
Yeah.
Yes, you would get
Right.
bullied.
So beyond all the different, techniques and interventions they can perform that other places can't, that's just a good example of what they can do, right? Because they can throw 15 people at a trauma instead of 6, right? So, trauma 2s, we talked about it, Ogden Regional, McKay, right? They have some specialties, as Mitch mentioned, right? They don't have those more detailed or specific specialties like hand and eyes and whatever else, right? They're going to refer some of their needs like open cardiac surgery and hemodialysis and so forth to a level 1, right? And then trauma 3s, we're all pretty familiar with Davis and late night G's capabilities or lack thereof. So, yeah, any questions about trauma designations?
Where's Lakeview on that? Are they a 3? Are they a 2, or what are they? They're not even?
Not even designated.
So like southbound I-15 or whatever, we're flipping around, or?
They still got blood, they still can do some stuff, but they're not a designated trauma center, so.
There you go. I would suggest that we all get familiar with our receiving trauma designations. So what classifies a patient as a trauma 1 or a trauma 2 or a trauma 3 at Davis Hospital and Layton Hospital and McKay, right? I was out of town for a while. I didn't get around to getting those. I should have talked to Jalen and whoever else. I'll try and get them for the next round, but you guys are my guinea pigs, so I apologize for that. Like I said, I think it's important to be able to classify your patient as, hey, I'm coming to you with a trauma 1, or I'm coming to you with a trauma 2, just to get that out there, right? Because the ears are going to perk up, and then they're still going to have their criteria that they're going to go through, and they're going to decide if it's a trauma 1 or a trauma 2. But it's like saying STEMI alert or sepsis alert or whatever it is, right? If you can kind of get the ears to perk up, you're going to get taken a lot more seriously, so you don't get sent to room 17 or room 24 or whatever, right? That's my take on it. This is, I think we're all familiar with this incident. This was a couple years ago, or last year? Last year. I know Mike was there, Grace was there, not sure if anybody else was there.
I was there.
Gavin was there. Yeah, so this was pretty significant burn injuries, right? Not a multiple casualty incident, not an MCI, but for me, being a brand new medic, this was definitely the most I've been stressed by any scene I've been on. So I just wanted to talk about some of the things that I learned based on that incident, some of the things we did right, some of the things we did wrong, and then give you guys who were there an opportunity to add or subtract from anything I say, right? So got called, we were all, basically the whole city was over 53 doing wildland pump training, got called to an explosion. It's in this subdivision, right, just north of Ellison Park here. Obviously showing up, right, you can tell this is a pretty significant incident, blowing the wall off the house. One thing that, looking back, I thought was not the best start, right? What starts bad ends bad, and I think it went well in general, but on that what starts bad ends bad note, is that Chief Wilkes was the first person on scene, and you could tell immediately when he gave his size up that his voice was super amped up, right? And so what do you think happened to everybody else's heart rate? It went through the roof, right? Just the way he was talking, he said, you know, we have 2 critical patients, I need at least 2 helicopters, you know, but obviously not saying it that smoothly and without inflection, right? He was pretty worked up. So whether that's Chief Cook or the first driving officer or the first driving ambulance, I think we can all work on this, except for maybe Kelsey, because she doesn't care about anything. We can probably all work on trying to control our voice, right? Control our emotions when we get on a big scene like that. Just because that'll keep everybody else and ourselves more calm down, right? We're here to do a job. Nothing we do is going to make things worse, right? Let's just figure out how to do this the most effective way possible, right? One thing I think Chief Wilkes did well is, and you alluded to this earlier, is that he got 2 helicopters coming right away, right? And so I thought that was, because obviously 2 critical burn patients, we're hoping we're not going to go to Layton Hospital, right, or Davis. So we flew them both straight to the U, to the burn center there, right? Getting that early activation of HEMS was, I think, pretty crucial in preventing any deterioration of those patients in the, you know, we call it the golden hour, right? I'd have to go back and look at the times, but I'm fairly certain that we had them at the U in less than an hour, or at least close to it, right? So that was super crucial. Another thing that I think we could have improved upon is better assignments of who was on which patient, team roles, right? Just like we do in a good cardiac arrest, right? You have the team lead, airway, BLS airway, meds, and access, right? That's kind of how we run cardiac arrest, or in compressions. I think we could have done a lot better job there. It was super chaotic. Obviously, we started out pretty amped up based on the arrival report, and then we couldn't find the second patient because he was wandering around in the subdivision. Nobody knew where he was at. So our ambulance, I think it was Braley and Aaron, arrived, and then Mikey and I were right behind him coming off the engine. We started working on the wife, the first patient, and things were going pretty smooth because to start with, it was just the 4 of us, right? And things were going decently well. We were getting access. We were trying to get the patient warmed up. We were talking about moving her, so on and so forth, getting pain control on board. And then the next crew arrived, and this is where it kind of all fell apart, is that Josh and I both got bumped off of this patient to the husband, not knowing where he was at, not knowing who was with him, right? So we kind of did a quick run around through the subdivision to the next ambulance to try and find him. I popped my head into the ambulance, there's no patient in there, and so it's just spiraling, right? So clear, concise communication on the radio, clear identification of roles and responsibilities, I think would have alleviated a lot of that. And this goes for any trauma patient, but especially those more complex scenes where we have more than one patient, right? Whether we're working on the freeway or, God forbid, we have another explosion or a structure fire, right? With injuries there. So, this is pretty applicable to, I think, a lot of our potential scenes will go on, right? Last but not least, I think prioritization of treatments and being aggressive with your treatment, right? When obviously I moved away from the wife, so I can't speak to that patient's care going forward, but when Josh and I started working on the husband, we were shorthanded because to start with, for about 10 minutes, it was just the 2 of us, right? We probably should have gotten on the radio and asked for at least 1 more set of hands, if not 2 or 3 more sets of hands, right? And then prioritizing care, right? We need to talk about or think about what the immediate life threats are when a patient appears stable, but their injuries are super distracting, right? So for us, it was like, okay, well, let's get some blankets on him and get IV access, right? And somehow, neither one of them had airway burns, but looking back, I think we had every right to be aggressive, even though there was no indication of airway burns, that we should have probably RSI'd both of them like that. Because the potential was there for them to decompensate on the 25-minute flight to the U or however long it was, right? So
They end up getting 2?
Quite late. They were fine. So we can talk about this when we do burn trauma, but we in EMS overestimate the likelihood of airway compromising burns in general. And we were over intubating people for many, many years. Those 2 both did get intubated because they both went to surgery for debridement and stuff, but they did not get emergently intubated. So, surprisingly,
yeah.
And the other thing nobody talks about, or you haven't talked about yet, What other type of injury should you have been suspicious of with that?
Blast.
Concussive. Yeah, they could, I'm shocked that they didn't have some sort of concussive related injuries, both of them, so, for sure.
Yeah,
And I don't know if it got talked about on scene or not, because all I kept hearing about was burn.
sure.
But my thought would have been, what happened to them? Did they get
Right.
tossed? Did they get tossed against the wall inside? Even just the concussive effect that caused that is enough that it could have scrambled some organs, so.
Sure. Yeah, I mean, I discussed it on scene with the husband, and he said that, like, he didn't have any other injuries, he wasn't having any pain anywhere besides his burned areas.
Cool.
And I think our index of suspicion was pretty high for that, right? We're listening to lung sounds, we're, you know,
Good.
doing all the things. But like you said, right, the potential's certainly there. I think more so with the wife, because she was in significantly worse shape. Actually, so they ended up posting about it on Instagram, so I kind of looked through, and I won't identify them or anything, but I looked through their, you know, experience with it, right? And that was just kind of a weird burn scenario, that it was, they both got flash burns, right? It wasn't really that concussive force that you expect with an explosion, because it was just acetone fumes wafting through the house, hit one of the pilot lights, and, you know, flashed, right? So it wasn't really that blast injury, that explosion, it was more just like the air caught fire and then flashed out, and that was it, right? So, like you said, the potential was there. Kind of a weird coincidence that it didn't go that way, but other gas explosions, right? Natural gas, propane explosions, we certainly expect that a lot more, I think. So, one last thing, I think, kind of back on that communication, clear radio traffic, right? We ended up having to wheel the husband all the way across the subdivision to get to the LZ for his helicopter. And that was just total misunderstanding, confusion on the radio, right? We thought PD had an LZ for us on one side. They were 180 degrees off from where we thought they were going. And then we had 3 fire engines and a battalion rig parked in the way, so we couldn't take the ambulance over there, right? So making sure that we're doing our best to get those kind of contingencies and next steps in line, you know, the best we can. So I don't know if you guys want to speak to it, you who were there, Mikey, Gavin, Grace, you guys have anything to add that you learned? Or, like I said, that was, still is the biggest scene I've been on, the most complex and kind of the most taxing as a provider. So that's the stuff that I learned from it. I hope you guys can take some of that away. But, yeah. That's kind of all I got for you. Questions, comments, concerns? If you have any suggestions for what to add, what to take away, you guys are my guinea pigs, so this is the first time I've done this. I'm more than happy to change it as necessary, but
Did a nice job, really nice job. All right, get out of here. Go settle into your stations, enjoy the rest of your day. I sent you a video.
No, it's just about, dude, it's just about the table.
Well, I have a video. Oh, no.